According to the Medicare Payment Advisory Commission, improper payments in Medicare Advantage tied to unsupported diagnoses are estimated at up to $43 billion annually. This chart shows the rising pressure on providers, with coding-related denials jumping by more than 125% in just 1 year. This workforce scaling represents a massive expansion in federal oversight, as CMS increased its audit team from 40 to approximately 2,000 specialized medical coders. This expanded workforce is targeting every eligible Medicare Advantage contract, reviewing records for payment years 2018 through 2024. Recent audits indicate significant vulnerability for practices, showing that roughly 70% of selected diagnosis codes lacked the associated clinical documentation to support them. These gaps in historical documentation create an active financial liability that federal reviewers are now specifically equipped to uncover at scale. While audit pressure mounts, the transition to the CMS V28 model is simultaneously rewriting the internal logic of risk adjustment. This graphic illustrates the structural shift. While the number of payment categories rose to 115, the list of valid ICD-10 codes that map to them was cut by over 2,000. In practice, over 2,200 diagnosis codes that used to contribute to a patient's risk score no longer count under the new model. This chart shows the projected impact, with CMS anticipating a 2.45% average decrease in risk scores due to the V28 transition alone. Capturing accurate scores now requires moving past generic codes in favor of the hyper-specific clinical documentation the V28 model demands. Practices that do not update their documentation habits to match these V28 requirements risk falling significantly below their historical reimbursement levels. To close these coding gaps, many practices attempt to hire additional in-house staff, but this often exposes new operational weaknesses. Generalist coders often struggle with the annual recapture rule, where chronic conditions must be redocumented and recoded every single calendar year to count toward the patient's risk score. This chart breaks down specialized labor costs. A credentialed in-house coder averages $55,000 to $75,000 annually, plus 30% in overhead. These costs are rising alongside an 11.1% increase in operating expenses, driven largely by staffing pressures. Even when a practice successfully trains a specialist, turnover is high, with experienced HCC coders frequently leaving for larger health systems within 2 years. The combination of rising labor costs and constant training cycles makes an in-house coding team financially unsustainable for most mid-sized medical groups. Beyond the coding staff, the real root of audit exposure often lies in the provider's daily documentation habits. To survive an audit, every coded condition must meet the MEET criteria: monitoring, evaluating, assessing, or treating. Simply listing a diagnosis is not enough. If the chart fails to show evidence of one of these 4 clinical actions, the code will be disallowed during a federal review. Most in-house workflows are reactive, where coders flag missing details days after the visit, making it difficult for the provider to correct the record. Successful risk adjustment requires prospective chart reviews, identifying potential gaps before the provider even enters the exam room. Without this combination of pre-visit reviews and strict MEET documentation, a practice remains vulnerable to significant revenue clawbacks. Strategic outsourcing offers a specialized alternative to the limitations of generalist in-house teams. Staffingly provides dedicated, credentialed HCC specialists who work directly inside your practice's existing EMR to manage the daily coding queue. This access is managed through a secure infrastructure that includes SOC2 Type 2, ISO 27001, and HITRS certifications. The human specialists are supported by smart routing AI, which automatically identifies and prioritizes the highest complexity charts for immediate review. Additional AI audit layers perform continuous pre-billing checks to identify missing codes or documentation gaps before they reach the payer. This integrated model consistently achieves coding error rates below 1% across hundreds of practices. By combining AI oversight with dedicated specialists, this model establishes a continuous, high-accuracy revenue protection workflow. For most practices, the ROI of this specialized approach is immediate. This chart compares the annual cost of a dedicated Staffingly seat at roughly $20,700 against the $75,000 total footprint of an in-house employee. This transition is designed for speed, with a 14-day go-live window for EMR access, training, and protocol setup. The engagement operates on a month-to-month basis, with no long-term contracts required after the initial pilot. As the V28 model and federal audits tighten the margin for error, specialized outsourcing is the most direct way to protect your reimbursement. Contact Staffingly today to schedule your risk-free 14-day pilot.